Good morning. Can you guys hear me? Is the microphone on? All right. Well, welcome. Let me move this. Welcome to the 2016 Targeted Therapies in Lung Cancer Patient Forum. Did I make that sound exciting? Good. Let me move to this side. Where's my mic? Because we know that lung cancer is not always the most exciting, so I'm going to try to give it a little bit more energy as we get started. So welcome to the 2016 Targeted Therapies in Lung Cancer Patient Forum. You know, there's some people that are thinking, how does that work together? Does that work? Well, if I'm up here, we're going to make it work. We're going to make it work. So we got to have a little bit of excitement. I've got some notes here of some amazing things that I want to make sure I read that are right on with our amazing people that are coordinating this event. So you guys know Cancer Grace. We know it. So let me switch this microphone here. But I want to make sure that you guys have some specifics about the group. So before I get into those, I want to tell you guys thank you for being here. Thank you for making this trip. Thank you for making this a priority. We know that the people that are here, you guys are not just survivors. You guys are, in most cases, survivor advocates. You're people that are going to grab this information, all of this knowledge, and you're not going to just keep it to yourself. You're going to take this knowledge in, you're going to soak it in, and then you're going to go share it. You're going to go give it to other people because you know it's important. And you're not going to just do it to the ones that are just similar, but you're going to make sure that people that are outside this place understand it, they get it, and then they can understand lung cancer that much more, right? So, grace, what is grace? I mean, you know, sometimes we abbreviate things and all of a sudden you just don't know. Somebody asks you, well, what is grace? And you're like, it's an organization. Well, if you guys were wondering, what is grace? What is Cancer Grace and what is this amazing guy, Dr. West, what did he put together? It's the global resource for the advancing of cancer education. If you didn't know, it is the global resource for advancing cancer education. And we're just so excited that that there's this tremendous collaboration with the University of Colorado. That's why this program is here. They have been tremendously supportive in so many programs. And so it's just natural that this conference would be here this weekend. So a little bit about Grace. Grace is a patient education nonprofit that was founded by this guy right here, Dr. Jack West. Give him some love. Give him some love. So founded in 2007, amazing, 10 years. This is 10 years, all right? Next year. So we're working. Tremendous. Grace works to get information about lung cancer options to patients through events like this, online videos and podcasts and news updates and commentary from leading doctors. This year, Grace created a lung cancer video library, which is 120 videos covering every stage, subtype of lung cancer. You can find that at cancergrace.org. Soon, Grace will launch a Spanish language lung cancer video library. I should be able to help with that, but you know, those 4 years of Spanish really have not taken. I can understand it, but I can't speak it very well. That's one of those common excuses. So on November 4th, Grace will hold an event for squamous cell lung cancer patients at Chapel Hill at UNC. Like today's event, it will also be broadcast live on the internet, so we are live. Where's the camera? Hey, there we go. We're live on the internet. And more information, again, go to cancergrace.org. So Grace has also expanded its educational program in the head and neck cancers and blood cancers as well, which again will go on the internet. And then blood cancers video library, webcast series on HPV-related head and neck cancers also. So a lot of great work that's happening. You see the commitment, 2007. You know, a lot of you guys, you've been around for that, you know, since 2007. You can understand, unfortunately, by being a part of this lung cancer space, how much has changed. And we know that it's a dramatic change that's happened since 2007. So the commitment of being able to put something together. We know when we see it, again, you say 2007, but you know based on being in this space that so much change has happened in the last 5 years. So anybody that decided to do anything before that, they knew that there was a nice brick wall in front of them, and they were willing to try to fight to knock it down. So why am I up here? So why would they ask me to come here to this lung cancer patient forum? And I think like so many people in here, you did not jump up in the morning and say, I'm going to be a lung cancer advocate. You didn't come up with a whole bunch of energy and walk around and you said, oh my goodness, it's a beautiful day. Look outside. The sun is shining. You're out here in Denver. Where's Hazel? Hazel's in here. There she is. You're thinking, I want to go hiking. All right? Or if it's wintertime, you're like, I'm going to go to Breckenridge and I'm going to go skiing. I'm going to do this. And then you're like, and the other thing I'm just thinking is, I want to be a lung cancer advocate. Those things don't just usually go together. I mean, I'm saying that. Maybe there's a couple of people that kind of thought of that, but not so much. Not so much. So why is it? Why am I here? Why does this, where's my connection? A lot of you guys know my wife, Keisha, was diagnosed with lung cancer December of 2010. So I was just finishing up in the NFL. I was with Washington Redskins in training camp, came back home, and Keisha was challenging me to do P90X and run a 10K. And for all you guys to know that P90X is serious. It's not the 10-minute trainer that they're trying to sell right now. It's in the hotel, they have that in the hotel rooms. It's like 10-minute trainer. It was the real P90X. And then 10K, running a 10K, that's 6 miles plus. And for a guy that's played in NFL for, was about 13 years, you know how far, for my Florida State guy, you know how far we run. At the most, 60 yards. Hopefully that means I'm scooping up the ball and I'm running it back and scoring. All right, and that's happened a couple of times. They took away my touchdowns. I'm still working to get those back, okay? So that was my, what is lung cancer? So it's in amazing shape, has a little shortness of breath, goes into a primary care doc, which she had a tremendous relationship with her primary care doc. And he says, let's just get a chest x-ray. Gets a chest x-ray. She has a mass in her left lung. It's right around Christmas time, and it's probably not the best time to be diagnosed, but he became that quarterback and went right after it, said, let's go get a biopsy, talked to oncologists, other doctors that he knew, and went and got the biopsy, confirmed that it was cancer, got a PET scan ordered, and really the first day we went in to see the oncologist at Emory, found out it was stage 4 lung cancer. Craziness. 37 years old. How does that happen? 37 years old, and you find out the most important fact of lung cancer, that anyone can get it. And somebody could say that. They could tell you that. Anyone can get lung cancer. You're like, yeah, anybody can get lung cancer. And then 37 years old, right in front of you, gets diagnosed with lung cancer. Now, one of the great things about being at Emory is that we had a doctor it's great. He's out here at Kaiser Denver right now, actually trained out here at the University of Colorado, is good friends with this guy right here that I get to introduce. His name was Dr. Scott Kono. And so in 2011, before crizotinib was approved, they were showing some great opportunities with it. So first thing they did was get her tested for EGFR and ALK. Now, unfortunately, she was negative for both of those, but that was a commitment that at that time wasn't happening across the country. They knew that if you're positive for both of those, that there could be something amazing that happens. There could be something that is different. There could be something that would allow you to take some pills where if you're at the Spring Hill Suites and you're milling around and hanging out, there's a whole bunch of other people that were over there and they're getting ready for something they got going on. And I'm thinking as I'm eating, how many of them realize that there's a bunch of lung cancer survivors just right in this room with them? I mean, I really was. I was tempted to go around and kind of interview folks and say, hey, you see that person right over there? What you think they got? You think they got lung cancer? I was very tempted. I was tempted because we're sitting there looking and it's like, all you guys just chilling and nobody knows. But that's what lung cancer, that's lung cancer. But then that's also what the possibilities are. So that's why, again, I'm excited to be here as we talk a little bit more about how targeted therapies are changing, the specifics of it. I'm excited to be here because we got, again, some tremendous survivor advocates that you guys aren't going to just sit on this information. You're not going to just absorb it. You know you want to be as knowledgeable as possible. We know that empowered patients it is critical. But I know you guys know how important it is that you share this information with everyone else. So there's somebody who's over there trying to think about, they just got diagnosed with lung cancer, and they're just lost, and they need some help. They need somebody to encourage them, and they need somebody to tell them that there is real hope, and that hope is in the science and with the docs that are really leading that science. There's things that are moving forward. So going back with my wife, we spent that time together. Unfortunately, she wasn't, with EGFR and ALK was negative for both of those, so was on standard chemo. Ended up progressing down through that year, and we had a chance to be married in November. And on that day, we made 2 commitments. One to each other, and the other to the community, to the cancer community, to the lung cancer community. And she passed a month later. But as we thought about what can we do, what is it that really needs to be done within this space, and we talked about with people in terms of awareness. They said awareness, we need awareness. People need to know. They need to know. And it says yes, they need to know lung cancer, but they know lung cancer is bad. What they need to know is the people that are affected by lung cancer. That's what was missing. That's what our commitment has been through our Team Draft initiative, is making sure that people, when we talk about awareness will not just be because lung cancer matters. Lung cancer doesn't matter. I can't stand lung cancer. If we could put lung cancer up and make it like a running back that I don't like, I would jack up lung cancer. I'll probably get about 10, 15-yard penalties because I will be kicking it and just extra, all right? We do not like lung cancer. We hate lung cancer. You know what I'm saying? I'd get kicked out of the game, especially now because it's, you can't do all that stuff now, right? But it's about the people. It is all about the people. And what we've seen with targeted therapies is that the individuals really matter. How is their cancer? What is their cancer? What does lung cancer look like in our individuals? And if we can understand that, then we can treat it. The more we understand it, the more we move forward. So, we're not fighting for lung cancer. We're not fighting for that. We're not fighting just to bring awareness about lung cancer. What we are fighting for is the people that are affected by it right now. We are honoring the people that have passed, that have committed to making a difference. We're fighting for the people right now that are dealing with it. We're here. We're empowering them. We're uplifting them. And then we're investing in the future. Because if we can see that all the folks in here can get it, if I truly believe that anyone can get this disease, if I really absolutely believe that anyone can get it, then I should think that I could get it. And so in being here and supporting the tremendous work that is happening, not only am I honoring my wife, not only am I fighting for you guys, but I'm also fighting for myself. So with that said, it is my honor to be able to introduce this tremendous guy who's sitting in the front. You guys might know him. He's got a little bit of a British accent. He's a guy that, when you come to Colorado, you know who he is. Mr. Dr. Camidge.
I don't think I can follow that. All right, here we go. That was Chris Draft, in case you were wondering who that guy was. He didn't just walk in off the street. All right, so it's my job to welcome you to the day and to just give you the kind of housekeeping issues. So first of all, we have to say thank you to the people who've helped make this possible. So these are our sponsors. And some basics. So we're going to be going between several rooms. This is the auditorium, if you haven't already figured it out. We're also going to be using rooms, I can't remember, it's B, C, and D. But anyway, they're on either side of the auditorium out there, and there are restrooms beside each one. So you have a relatively small space that you're going to be going through. We are a mile above sea level, so those of you who are new to Denver, if you're getting headaches, you're probably getting dehydrated. It's not overindulgence from the night before, it's underindulgence in hydration. If you get really out of sorts, the emergency room is immediately to our west. Let's talk about what we're going to do today. Well, we're about to go into the first session, and we thought we'd jump straight into controversy. So we're going to look at the idea of using radical treatments, surgery and radiation therapy, about whether they're ever sensible or they're ever crazy for using them in quote-unquote incurable disease. So can you use a curative modality when somebody says, well, I've got stage 4 disease? And we're going to have that talk done by Rob Meguid, who's one of our great thoracic surgeons. And then afterwards, we'll have a panel, including Rob, Chad Rusthoven, who's a radiation oncologist, myself to represent medical oncology, and then Jack West, our spiritual leader, will chair the session. Then we're going to divide and conquer. Everything that's happened in lung cancer has been splitting you into separate groups and treating you differently. And we're going to educate you differently in that way. So there's going to be an ALK positive track, which is going to be in the auditorium here, a ROS1 positive track, which is going to be in room A, and the EGFR mutant track, which is going to be in room B. And in each of those sessions, we have key faculty member, both a physician and a patient champion. So for ALK, we have from Karmanos, Shirish Gadgil. Stand up and wave, Shirish. Okay. And the patient champion there, Linnea Olson. Linnea, where are you? Excellent. In the ROS1 track, we have Caroline McCoach, who's our senior fellow. I'm hoping you're going to learn her name a lot in the next few years as she builds her academic career. Caroline, stand up and wave. And Tori Tamalia. Where's Tori? Right. And then in the EGFR mutant track, from Memorial Sloan Kettering, Greg Riley. And Bob first. Where's Bob? And Jack and I are going to be popping in and out of various sessions. Jack, I think, is mostly going to be in the EGFR session. I'm mostly going to be in the ROS1 session. We're going to have 2 separate sessions so that you don't have to cram everything into the first bit. We're going to have some presentation, some discussion. There's going to be a break. We recognize people need breaks. You're not programmed like academics to sit there and absorb information for hours and hours. And then at the end, there's going to be lunch and a lunchtime lecture. During the lunchtime lecture, apart from having lunch, Dara Eisner, who's one of our great molecular pathologists, is going to explain all of the wonderful details about molecular testing. She's one of the few people in the world who can actually make it intelligible and interesting. And then in the afternoon, you get choices. So there are breakout sessions, again, room B, D, A, and the auditorium. I don't know what's wrong with room C. Clearly, we didn't like it. Nothing good going on in room C. And the way it works is you get to choose, in the first bit, you get to choose 1 out of those 4. You go through it, and then in the next session you choose another one of the 4, and then the next session you choose another one of the 4. And they just repeat. So for example, you could start with Cancer Kitchen, where there'll be a demonstration of cooking. Then you could go to combating chemo brain. And then you could go to exercise for lung cancer patients. Or if you prefer, you could do dealing with the down days, difficult emotions during cancer, combating chemo brain, and then Cancer Kitchen. Or if you have really bad chemo brain, you could just stay in the same session all the way down. There's another little break, and then in the afternoon session, you only get to choose 1. So these ones don't rotate through, but you just get to choose 1 of the 4. We have bankruptcy and workplace discrimination, love, sex, and lung cancer, which is a great novel. It's flying off the shelves now. Where there's smoke, is there fire? Marijuana and lung cancer. We are in Colorado. We have a great guy called Dan Bowles, who's a real expert in this. And then recharging the caregiver's batteries. And then at the end of the day, there's going to be a reception, and that's just going to be in the lobby area outside. A couple of points. I know that nobody comes to these things because they're abstractly interested in lung cancer. They're here because they're affected or their loved one is affected. So a couple of points. There are a couple of people who've registered who don't have ALK, EGFR, or ROS1. And you may go, well, what do I do? Well, obviously you can get something from the general sessions, but in terms of the breakout sessions, just choose 1. Just choose one and go into it. The Ross one is the smallest one, so if you want to make the numbers look more equal, that may be the one to go into. I think what you should get from that is you should look at these other people as pioneers and you say, well, what has that group of people done and what can I learn from that? About your individual case, though, just a little bit about etiquette. In the same way that whilst, when we look at pictures of other people's children, we all smile and nod, eventually it gets a little boring. So standing up and saying, what about my case? Just respect the other people in the room. If you can phrase your question in a way which is a general question, so something about your case may be educational to other people, great. But if you get down to the nitty-gritty, should I have my scan next week or 6 weeks later, save that for a break. Save that and grab any member of the faculty just when you can. I'm hoping they're going to stay around even after their sessions. These guys are all experts. It doesn't matter if Greg is in the EGFR track. He knows a lot about ALK and ROS1. The same for Charisse, the same for all of the others. So just grab whoever you can and just get a free second opinion if you want to. We won't mind. Finally, as Chris pointed out, this is being videoed and live streamed. So keep the cuss words and nudity down to the bare minimum. There's in addition to the Grace folk here, there's a group from Catch It in Time. Is anyone from Catch It in Time here? Can you wave your hands? There you go, over there. They're wearing the black and purple shirts, which is also Colorado Rockies colors. They're also interested in picking your brain because they've got another website called the User's Guide to Oncology. They want to sort of test drive it. They've got some iPads they want to show you. So if they're looking around and no one's talking to them, go chat to them. All right, without further ado, we're going to move on to our first session. We'll make up the time in the break if we have to, and we're going to start off with Dr. Rob Meguid on Does NED Matter?
Good morning. Well, thank you, everyone, for your attention. Thank you for inviting me to participate. I'm very excited to be here. Let's see if this goes straight to my slide here. A disclaimer. So I'm a thoracic surgeon here on faculty and part of the cancer center, but I was up operating all night, so I apologize if I'm a little not quite as high energy as everyone's been so far. So this morning, I've retitled my talk about the role of surgery in the multidisciplinary management of lung cancer. And I'll explain that in a bit. What we're going to talk about first is the role of surgery in lung cancer treatment, and specifically in advanced lung cancer stage treatment, and then the utility of the multidisciplinary approach to lung cancer management. We're going to frame it in a few case presentations. So Mrs. P is a patient who several of us encountered and treated and are treating. She's a 67-year-old woman. She was a former smoker, and she underwent an annual chest x-ray for routine follow-up of her lymphoma with the unfortunate finding of a new lung nodule in the right upper medial lung field that wasn't visible on the x-ray from a year before. She came to see us in clinic. She was asymptomatic. She had no cough. She had no weight loss. A CT scan was obtained, and this showed about a 2-centimeter nodule in the lung. Fortunately, we didn't see any axillary or supraclavicular, any other lymph nodes enlarged in her chest. We obtained a needle biopsy that demonstrated squamous cell carcinoma, and a PET CT, which showed this was only isolated to the lung. Now, when I think about the 15 years of my lifetime in surgery and in patient care as a physician, in my management and my training, I think about the different advances we've seen in lung cancer. And we've had advances in the accuracy of imaging and the accuracy of diagnosis. We're finding patients at earlier stages, therefore able to offer them better treatment options and longer outcomes. We've had development in my field of minimally invasive surgical approaches, so patients after surgery recover faster, they go home sooner, they're back to activities sooner, they're back to work faster, and they have a better quality of life. We've seen improvements in their perioperative care where we're able to treat patients who are potentially sicker than we could in the past. There's been advances in radiation oncology, both instead of and as an adjunct to surgery. There have been a great deal of advances in chemotherapy in the past 15 years. And in the past few years, we've seen a rise of multidisciplinary clinics for assessment and management of cancers, various cancers, including lung cancer. And those have given us the ability as providers to meet face-to-face, to discuss patients face-to-face, to minimize communication breakdowns, to expedite patient care, to see patients as a combined effort. And I think we've been able to truly improve the quality of care delivered to patients with lung cancer and other cancers as well. However, there haven't been much of a change in the tenets of lung cancer management during this time. This is an example of a review article in the New England Journal of Medicine that I read when I was in training, and I still give it as prescribed reading to my medical students and my residents and my surgical fellows. And it's from 2004, which means the data was probably from 2000 or earlier. Dr. Ettinger was a mentor of mine when I was in Baltimore in my training, and I hold him in high esteem. But unfortunately, these tenets of care have not evolved much despite individual advances in each of our fields, which is frustrating. Now, where does this take us back to Mrs. P? So we had worked her up. We engaged in mediastinal staging, and then I did a minimally invasive lobectomy on her, and we were fortunate to find that she had stage 1B squamous cell carcinoma. Of the 26 lymph nodes we found, there were none that were positive for cancer, and as a result, that lung tumor is out, and we're now engaging in the prescribed follow-up of serial physical exams and getting CAT scans. We're on to the yearly CAT scans at this point. And that's wonderful. There's still a risk of recurrence, but it's wonderful for Mrs. P. And it's reassuring for the care we provide patients, and as a surgeon, it's reassuring as well. So the treatment of stage 1 and 2 lung cancers are based on accurate diagnosis, types of biopsies that we can obtain, accurate staging through imaging modalities, through nodal staging, either minimally invasively through endobronchial ultrasound or mediastinoscopy, taking out the primary lung cancer, either lobectomy or segmentectomy or occasionally pneumonectomy, but usually minimally invasively these days. Confirmation of the pathologic staging and treatment, and then deciding on the role for chemotherapy in a low-stage lung cancer, and finally developing a surveillance plan which we engage in. Now, stage 3A is much more complicated. There's much more that goes into stage 3A. It can be small tumors with nodal disease that spread to the middle of the chest. It can be larger tumors with nodal disease limited to the lung or spread to the middle of the chest. But the treatment is sometimes controversial. Currently, we, in general, prescribe to chemotherapy and radiation therapy followed by surgery. As a surgeon, I'm pleased that minimally invasive surgery is still an option after radiation therapy. It was often discounted, but we're seeing in the past decade that that's not really the case. So let's talk about minimally invasive surgery as a surgeon. Many of you are familiar with it. We often call it by the moniker VATS, or video-assisted thoracic surgery, or thoracoscopic surgery. And this is a modality to both biopsy and treat lung cancers. We can resect it or biopsy a nodule. We can take out an anatomic segment of a lung, such as a lobe or a segment, or potentially a pneumonectomy. We can reach lesions throughout the lung and concurrently sample lymph nodes, pleural fluid, the pleura, and obtain more information. Here's a little cartoon of a minimally invasive approach with a camera and small instruments between the ribs without rib spreading. But there are limitations. If the patient won't tolerate lung surgery, open lung surgery, they certainly won't tolerate minimally invasive lung surgery. But sometimes if the tumor is too bulky or too close to the blood vessels, it's not necessarily a safe approach, in which case an open, more old-fashioned, if you will, approach is reasonable. So when we think of the surgical role in advanced stage lung cancer, in my training, minimally invasive surgery for lung cancer was not an option for advanced stage lung cancer. And I'm seeing that that's really not the case. There's numerous areas where advanced stage lung cancer falls outside the box of the NCCN guidelines. And again, we'll highlight the role for multidisciplinary approach. This is an example of a patient with bilateral lung nodules, for instance, and we'll spend a little time on that. So when is surgery an option for advanced disease? When we see solitary or limited metastatic disease, such as a nodule in the brain or the adrenal glands, so metastasis that's isolated. When we have oligometastatic disease or distant relapse limited to a few number of regions which may be resectable technically and the patient would tolerate it. Or oligoprogression where the growth is limited but still resectable. When we have disease that may represent concurrent low-stage cancers or metastatic disease. And we'll spend a little more time on that. And when we've seen a favorable response to chemotherapy that may have been initially ruled out as being a surgical or radiation management option. And then when we have new growth and we can consider re-resection or retreatment. So another patient that all of us have treated, Mrs. K. She's a 75-year-old woman. She was a former smoker. She had multiple lung nodules found on a screening CT scan, which she engaged in from her history of smoking. And on imaging, we found 2 nodules in the right upper lobe of the lung. One was 14 millimeters, one was 12 millimeters in size, but they were near each other. On the left side, there was a very subtle ground glass opacity, possibly representing a cancer, and a cavitary nodule, 15 millimeters inside again, possibly representing a cancer. She had enlarged lymph nodes in the middle of her chest and in her lung on the right. And this is where, in the past, in my training in the past, in my exposure in the past, looking at this as a surgeon, I'd say, well, I'm not sure there's a role for me as a surgeon, and move on to the next patient. But in the opportunity to discuss this at a multidisciplinary lung cancer clinic, which we've had ongoing for a few years, and a tumor board for even longer, it provides an opportunity to find out different opinions and make sure we're not coming to conclusions too rapidly. So in this example, it's a little technical, but in this example, this patient had right upper lobe nodules that were suspicious for cancer. We decided as a team we'd pursue a CT-guided needle biopsy, and if they were positive for cancer, then work up the cancer fully. The left-sided nodules, we talked about, they were somewhat indeterminate. We decided while we're working up the right side, we can just watch those for the time being. That left-sided ground glass opacity, we're set up to watch as well. So Mrs. K underwent a needle biopsy. It did show that one of the nodules, nodule number 1, was an adenocarcinoma, and nodule number 2 was non-diagnostic. So it's unclear. It was small, it was deep in the lung. Did the needle not get it? Is it just an old infection? So we still don't know. We obtained a PET CT, and this showed that both of those nodules on the right side lit up on the PET CT, hinting at cancer. The lymph node in the middle of her chest on the right side also lit up. But we didn't see anything light up elsewhere, so those nodules on the other side didn't light up. Her brain MRI didn't show anything suspicious, thankfully, and she had good heart and lung function. So when I think of her as a candidate for surgery, when Chad thinks of her as a candidate for radiation therapy, or Ross as a candidate for chemotherapy, those are all favorable. We re-reviewed her once we had more data. We now knew she had a right upper lobe of the lung adenocarcinoma. She was potentially a stage 3A, so she had a T3N2, so multiple nodules in the same lobe and a lymph node in the middle of her chest, or possibly stage 4, because we still don't know what's going on the left side. And there's a big difference in the treatment options, and especially as a surgeon, there's a big difference in the treatment options. So we decided we'd move on to try and find out what's going on with the lymph nodes. If they were positive for cancer, we discussed the role for induction chemotherapy with additional workup ongoing. She underwent endobronchial ultrasound, so a minimally invasive approach down the trachea. One of the lymph nodes was found to have cancer in it. The other lymph nodes were non-diagnostic, unfortunately, which is one of the situations we often run into with some of these techniques. So I performed mediastinoscopy, confirmed that we had lymph nodes on the right side of the chest that had cancer, but the lymph nodes on the other side of the chest did not have any evidence of cancer. So now we're still faced with, is she a stage 3A or a stage 4? But we're starting to refine our information a little better. Well, per the plan, we had discussed with her, she underwent chemotherapy and radiation therapy. We repeated the CT scan after the imaging, after the treatment, and the right-sided nodules were stable, The lymph nodes in the middle of the chest had decreased in size, and the left-sided nodules had decreased in size. And what I didn't tell you, there was a CAT scan before the chemo and radiation that showed the left-sided had decreased in size a little bit as well, which was very encouraging. So we re-reviewed her at our multidisciplinary clinic and said, okay, well, probably the left-sided disease is not related to the right-sided cancer. So rather than condemn her to a stage 4 therapy and prognosis, let's proceed to a surgical management. So we performed a thoracoscopic right upper lobectomy and completed a mediastinal lymph node dissection. She went home 5 days later. We were surprised. The nodules on the right, nodule number 1, had less than 10% viable tumor, so it had responded very well to the chemotherapy. Nodule number 2 had not responded as well. The lymph nodes in the lung and the mediastinal dissection didn't have any evidence of cancer in them, so there'd been some response from the mediastinal lymph nodes. We obtained molecular testing to compare the nodules to the lymph nodes from our prior biopsies, and we found that the lung nodule number 1 had the same mutations in the lymph nodes from the prior studies, but lung nodule number 2 did not. So now we have a different situation. We have a T1B N2, so again a stage 3A, and a concurrent stage 1B. But we didn't have a stage 4, which is very encouraging when I'm thinking about her prognosis and our treatment options. So she met with medical oncology, discussed further treatment, and then has ongoing surveillance for both recurrence and of the left-sided lesions. Now, a year later, which is this past summer, our follow-up imaging showed the left-sided lesions have decreased in size. The cavitary lesions decreased in size, probably representing an old infection, which we see commonly in this part of the country. The ground glass opacity has persisted but hasn't changed in the nature, so we're still following that. But there's no evidence of recurrence, there's no evidence of progression, and she doesn't need additional treatment right now. So this is, to me, a wonderful situation to have a patient go from, if she'd crossed my desk several years ago, I would have thought, okay, stage 4, I don't need to see her, there's nothing I can offer her, to someone who we can potentially render disease-free. That is really driven by our multidisciplinary approach to lung cancer. And again, the benefits, so yes, we can see patients with suspicious findings and new diagnoses of cancer, and we can expedite their care and meet with them as a team and provide a common proposal. But we can see patients with recurrent cancers. Beyond that, we can come up with a svelte or streamlined workup for staging. We can discuss various management options. We can treat patients who range from the simple side of the spectrum, like we talked about with the first patient, to the more complex, like Mrs. K. But we can treat patients who are outside of the box, where the NCCN guidelines fall short, where we don't have consensus, and where we can sit face-to-face and talk about the different options that exist and find out what's really best for the patient, not what's easiest for me as a provider when someone comes to my clinic. We can discuss options for involvement in cancer trials, which is phenomenal as well. So with that in mind, I'd like to, again, thank you for your attention. We're going to be up here in an opportunity to ask questions and discuss some different options. And I do want to thank not only the team and Grace as well, but the Lung Cancer Multidisciplinary Clinic, which I've seen evolve over the past few years, and it's a critical aspect of my career to be part of in my ability to care for patients. So thank you all very much.
We can have the radical treaters over there.
Okay, exactly. Local versus systemic.
Yep.
Okay. So great, thanks so much. We'll start with a series of questions that I think are going to be pretty general about this, and then as time allows, open up to any questions that we might be able to have. One would be, you brought up, Rob, that this was a patient who technically is not stage 4, but I think that the biggest question, at least among the people in this room, is the potential utility for local therapy in patients who have established stage 4 disease. And the question of, is there clearly, or the dictum that there's no role for local therapy for patients with known metastatic disease may not be true. So why don't we just start with the question of, is there a potential role for more indolent disease? And I know that there are many patients here that could be a de novo untreated with systemic therapy or on systemic therapy, to receive local therapy if they have a background of even visible disease, but only 1 or 2 lesions are growing. And maybe I'll start with you, Rob, and then Chad.
Thank you. Yeah, I think that's a very reasonable question. And again, as we all know, it's not a straightforward answer. But in certain circumstances, it is very reasonable, I think, for us to pursue local management, either with surgery or ablation. And obviously, it requires a patient who has had stable disease elsewhere, who's healthy and will tolerate the treatment we offer them. But I think it's hard for me to condemn a patient to no treatment when we have a situation that looks like it could be managed with local therapy.
Chad, what do you think about, and particularly the question of, we talked about getting to NED, and I might say that we don't have to necessarily get to the point of NED if prolonged stability is for a very long time. I mean, making a previously shorter-term disease a very chronic disease is still a very valuable thing, even if it's not strictly curative. And so to me, is there a clear imperative to get to NED if you can more easily get to the point of treating all growing disease and leaving some in the background but stable?
Yeah, I think that's a very good point. So, classically, and as Rob was touching on in his talk, we're taught in a certain way in med school, and kind of the dogma for the last number of decades has been patients who have metastatic disease are treated with systemic therapy, and that local therapies like radiation and surgery are taken off the table. Today, I think our view of metastatic lung cancer is really evolving, and we're thinking more about controlling disease and treating things like a chronic illness, and looking for ways that we can benefit patients in terms of progression-free survival and quality of life that don't fall neatly into our older definitions of cure, which would be indefinite progression-free survival, where the cancer never comes back. We're finding ways where we can still benefit patients by treating things locally without that classic definition of cure. And this is something that we think about a lot at the University of Colorado. We're probably very open to that idea, I think maybe more so than we've been early adopters of the idea that local therapy could have a role for these patients. I think particularly as it pertains to this conference, I think that for patients who have targetable mutations where we're able to offer targeted therapies that are very well tolerated and very effective, I think that the enthusiasm for local therapy when spots pop up here and there, my enthusiasm personally goes up, because one of the things that we found here is that patients may be on a targeted therapy like crizotinib, and they may be doing well for 12 or 18 months and then have 1 or 2 spots pop up. And instead of just getting rid of this very effective, reasonably well-tolerated drug and going to the next line, sometimes we can actually keep these patients on crizotinib that they're tolerating well and treat the spots that are emerging and showing more aggressiveness. And we can stretch out the duration of access to these really great drugs, and more drugs are being approved all the time in this setting. And when you start lining those up, you extend an extra 6 months or so with crizotinib, and then the next line, if you can extend that a little bit, and you can extend the next one, you can start to add these things together, and they start to make, I think for the right patients, they can make meaningful contributions to their quality and length of life and keep them being able to do the things that they like. And it's really been a paradigm shift for us as radiation oncologists to say, okay, now we have this technology that we can go after things in a very focused way, in a safe way, in an effective way. How do we use that the right way, where we're not bringing patients for treatment that's not helpful? How do we select the right patients in the right time and do things in a way that's likely to benefit the patients? And that's something that we're still learning.
Right.
But it's been a really exciting development and something that certainly here we've been very interested in for a while.
How about the question of, particularly say with a lung lesion, but this could apply to anything from brain to adrenals or other locations. There's a couple of leading modalities for local therapy with radiation and surgery. So let's limit to that. But what are the situations that make you more inclined to favor a radiation or a surgery-based approach in terms of anatomy, size, location, things like that? So yeah, because I think that surgery's been around for centuries and refined all the time, but there's been also a lot of improvements in the radiation front that have made I think the questions not only of the benefit, but even with an uncertain benefit, when the risks get low enough, that lowers the hurdle quite a bit to adopting a strategy.
Well, there are times where it's where both surgery and radiation are very viable options, and in those cases, we'll typically have a discussion together, and you try to weigh the risks and benefits and take the whole patient picture into account. For a patient who's very healthy with a single lesion that everyone agrees that we should address, I think you think strongly about surgery in those instances. As patients may become, for older patients or those who are unhealthy or may not be fit for surgery, or we may have a number of lesions that really can't all be addressed with separate surgeries in separate spots, I think less invasive things like radiation, the risk-benefit ratio tends to start to favor those type of therapies. And then there's everything in between. But both can be very effective, and as you touched on a little bit, there are other local therapies that we might consider given the situation. So those are kind of nuanced questions that take a lot of things into account, but we tend to think of both surgery and radiation as very effective means for going after isolated lesions.
Rob, in terms of location of a more deep and location in the lung, what are the factors that you use in weighing whether surgery or radiation is a stronger option?
Yeah, so for surgery in the lung per se, I usually look at not only number of lesions, but where they are clustered, if there's an ability to affect a good response by taking out multiple lesions with minimal resections, and preserve patients' lung function so they can have quality of life. When we get to a situation where we have multiple nodules throughout multiple lobes of the lung, that may not be amenable to simple wedge resections, but may need deeper resections like segmentectomies or lobectomies, you start to think about the cost benefit. The cost is going to be more to the patient in terms of their recovery, their functionality, their quality of life afterwards, versus using radiation therapy to target the individual lesions. And we use that not only for lung cancer, but for, unfortunately, other diseases that metastasize to the lung, such as sarcomas, where we found the ability to use a combination of surgery for more accessible lesions that won't deprive someone of their lung function, and then use radiation therapy for additional lesions that we can't readily get to.
This is all talking about essentially asymptomatic disease. I mean, in the setting of metastatic disease, we've long held that if someone has a painful bone metastasis, you treat that, or is coughing up blood, has hemoptysis, there's a role for radiation, et cetera. But in the setting of known metastatic disease, there was a trial that was presented by Dr. Gomez and colleagues at ASCO this year. Dr. Gomez is a radiation oncologist working very closely with Dr. Steve Swisher, a surgeon, a thoracic surgeon at MD Anderson. And I know your center also participated in that. It was a trial that, to summarize, took patients who had stage 4 disease and received 3 months of initial systemic therapy that could be chemotherapy if you didn't have a driver mutation, or EGFR or ALK-directed therapy if you did. And if patients didn't have progression of their disease and had, I think, 3 or fewer sites of residual disease present, were randomized to either maintenance or surveillance alone, or consolidation. They called it consolidation therapy with radiation or surgery and whatever combination, sometimes chemo and radiation. And they looked at progression-free survival and saw there was a very significant difference in progression-free survival in favor of the recipients of the local therapy. Now, I was actually one of the discussants, and I was critical of that endpoint. And I think it raises the question, I'll be interested in Ross's and everyone's sense of what's the goal? I mean, progression-free survival, if it's just making the scans look better, I don't know that we can't do just as well with Adobe Photoshop. And the goal isn't...
Depends on how good you are with
yes,
Adobe
right.
Photoshop.
But just for the sake of making scans look good, that's not a big help. But if it changes the trajectory of the disease, ideally how long people live, and as an earlier proxy, the time before new disease progresses in other places, I think that's a huge finding. And one of the things they did incorporate in their final analysis was a look at the time to new metastases that showed that it delayed the time to metastases. It should be said that this was a limited subset of just under 50 patients drawn from 3 major centers over years. So, and patients with pleural effusions weren't included. So we're talking about a pretty selected group of people, but it is very provocative if it suggests that local therapy can change the systemic trajectory of disease. And so I'll just bring it back to say, Ross, for instance, if you have somebody who has local progression of their disease on a systemic therapy, could be chemo or a targeted therapy, what are you thinking about? What is the goal, and what do you think we're realistically going to get from local therapy? Is it largely the psychological gravitational pull of being NED, and how valuable is that, versus and just being able to say, and now we can continue what we're doing? Or is it actually changing the biology of the disease for a bigger picture?
Well, my take is, if you go back to that slide that Rob showed early on that sort of essentially said stage 4 disease, equals chemo, we're really attacking that paradigm in 3 different ways. So one is the kind of the study that Dan Gomez presented at ASCO, which is, you have relatively limited sites of disease to begin with, and the other shoe hasn't fallen. So you've gone through some kind of systemic therapy and the disease hasn't suddenly exploded. So you've got a test of time that reassures you that just maybe this is a cancer that might have relatively low metastatic potential. And then what if you go in there and you're probably not curing these people, but maybe you're destroying enough of the advanced guard of the chemotherapy, of the cancer, that it's going to take a significantly long time before the next bit of cancer emerges, and that's enough to change the natural history of the disease. That study, was interesting enough, was actually based on a thought experiment that was actually led by Chad's brother, who was also a radiation oncologist. It's like a
family business.
It's like a family business, the Rusthovens.
Yeah, exactly.
And,
nepotism. That's how he got the job.
And there, it was based on the observation that if you took people who had relatively limited sites of disease and you followed them going forward after their chemotherapy, where did their cancer grow? And not surprisingly, where it grew was where it originally was, not in a new site. And therefore, that's the thought experiment that says if you could therefore destroy the sites where you knew it was, you would buy the theoretical time before the new sites came up. So you gave a great analogy for the Gomez study about appendicectomy. Do you want to say that one?
I said, the problem is that if you obviate the chance to see the progression, it's not a surprise, that you're going to get success. I didn't like progression-free survival endpoint, because we know that if we randomize patients to a prophylactic appendectomy or not, that the rates of appendicitis are going to be lower in the patients who have had the appendectomy. The question is, so what? That's not a surprise. And is that really important in the scheme of things? And so but I think it totally changes things. If I use the analogy of getting the lead runner in a baseball analogy. Your biggest threat, and I think it's important to look at the situation, is if there's one process that's far ahead of everything in the background, that really makes sense to go after it. That's less valuable if you've got 7 lesions all growing at a comparable rate, that you're not going to really slow that process very much by going after 2 or even probably 7, because it's a more diffuse process. And I think that that's something we need to underscore, is that as much as that study and that analysis of time to distant failure, early and small numbers though it is, has made me step back and rethink my entire years of our dogma that you don't worry about local therapy in a systemic process. To me, that's a real change. And if it delays the time to a cancer evolving, that there is still a loco-regional aspect to a diffuse thing. But that it really matters that when we're talking about oligometastatic, oligo means few, and that doesn't mean that you can count 8, 10, 12 lesions and treat all of those, and just because you can doesn't mean we should. That's, to me, a big struggle.
And we can certainly see that so the other way that we've been chipping away at this stage 4 paradigm was the oligoprogressive scenario, which is, many of the people in this room are on a targeted therapy. It doesn't matter how many sites of disease you have, if 99% of them are all suppressed, and then, a year later, one pops up, it's like an early stage of progression. But even in our early series, we could see that the time it took before, if you zap that with radiotherapy or cut it out, the time it took, and Greg, you had the same study at Memorial Sloan Kettering, the time it took before the next lesion came up was clearly influenced by how many progressing sites you had.
Right.
And so it really makes sense for like 1 or 2 sites. I think at your site, was it just 1 site at your site? Yeah, so the Memorial Sloan Kettering, which had the biggest duration of control, was very conservative. You only had to have 1 site of progression. Our initial series went up to about 4, but if you had 3 or 4, it took a much shorter time before the next thing popped up than if you had 1 or 2. So again, it's that suggestion of what's going on that you can't see.
Right, and a subset analysis also of the MD Anderson-led study that you participated in also showed that that the patients, there was a steep drop-off after 1 lesion even, and certainly by 3 at least. So, but that really speaks to the how well localized that progression is, but it's not a binary issue of systemic or not. I want to get back to, with the local therapy question, one issue that we have, and I'm sure you guys deal with as well, is we are doing a lot more stereotactic body radiation therapy, SBRT, or you may read it as SABR, stereotactic ablative radiation therapy. Same thing, I think. But after you have that, you can't interpret what's going on very well near there. And we've even had things that seem to be growing, and you do a PET scan and it's PET avid. We've even done surgery and found, it was all reactive. How much is that a concern in the metastatic setting or even early in terms of this? You've got a couple of options. The radiation may be the most lung sparing, but difficult to really interpret what's happening afterward. Chad first.
Yeah, it can be a little bit difficult to interpret. So the stereotactic body radiation and stereotactic ablative radiation therapy, this SBRT or SABR, refers to high dose focused radiation, usually in 1 to 5 total treatments. That's really just going after a very focused spot. So, that's in stark contrast to kind of classic lung radiation, where we treat patients over 6 weeks to a large area in the curative setting. The SBRT or SABR is when we have a very defined target and we're trying to ablate that target and get rid of it like you would surgery and treat only that area. And that has been kind of a newish advancement in our technological capabilities in radiation oncology over the past decade, where that's really come into common practice. It can be difficult or at least more challenging sometimes to interpret scans after you've done that type of treatment. So it takes a lot of communication between medical oncologists and radiation oncologists and kind of co-reviewing scans and making sure that we're on the same page. And it takes some patience. What we know is that when we do that, when we do SABR to a certain dose, we know that our control rates are very good. And so that gives us some, I think, leeway to be a little bit more patient in interpreting scans and being willing to wait before we might think that we need to do additional therapy like surgery in that area. So it takes a lot of communication, it takes patience, and it takes the radiation oncologist knowing what the chances of control in those areas really are with the doses that we offer.
Rob, have you factored that issue into any counseling to a patient, and have you had situations where you've done a post-SABR resection and found that there wasn't cancer, but it just looked for all the world like it was likely to be?
Sure, as a team, we've encountered both scenarios. Again, to echo what Chad said, there are patients who are clearly great candidates for surgery and patients who clearly would benefit from SBRT rather than surgery. And then there's the overlap in the middle where you have to have a much more detailed conversation to let the patient, to inform the patient to the point where they can make an appropriate decision for themselves as to what they think is best. And I think as physicians, we really need to advocate for that type of engagement. The issue of is there still cancer there? We've all seen with both, there's thankfully no cancer there. We thought there was, or we weren't sure, there's a little growth, we checked it out, and unfortunately there was recurrence. I think from my personal experience, I've seen more of the latter, but I'm hoping we can see more of the former and move to the point where we can get accurate diagnostic testing to say, okay, there is no evidence of growth. I think this is where imaging has evolved and improved, and I'm optimistic that that will keep improving and guide us better so we can avoid operating on no evidence of disease.
Well, I mean, we're always struggling with this balance of not over-treating, and that also includes you don't want to do a bigger wedge resection than you need to. You don't want to have a wider rim of radiation therapy around the lesion. But a lot of I know from talking with already several people in the audience and my own patients that we're often talking about ground glass opacities that have wispy edges that are microscopic even, and you can't see. And sometimes these are the cases that the surgeons I work with, you have to revise the margins over and over again because they come back as positive. So it seemed like over time, you're trying to do the best you can in terms of radiating or resecting. At least with the resection, you have the feedback of pathology. But radiation, you can't know exactly whether you've gotten to the very edge of a lesion or just at the edge of where you've treated. There's still going to be viable disease that takes 2 years to grow. And I think this is where we're going to struggle with ambiguity, especially with SABR has been growing in utility and experience, but just over the last few years, and nobody has a little more experience in Asia, but we're all learning as we go. So we're going to have to get more experience in the next few years with this.
Even more common as we get better systemic therapies to treat ALK-positive and EGFR disease. And some of these drugs are not so great at penetrating into the central nervous system. So if over time we're controlling disease in the rest of the body, that gives more time for metastases ultimately to develop in the brain that may not be effectively treated with these drugs. And so although radiation has always been an important modality for treating brain metastases, it seems to have a special place for patients with ALK or EGFR mutated lung cancer who are receiving first-generation inhibitors like crizotinib or Tarceva. So our general approach here is that we try to be aggressive about controlling brain metastases with radiation for patients who are on these drugs that are not as effective inside the central nervous system. And so our preferred approach is typically to offer stereotactic radiosurgery, which is a very focused way of treating brain metastases on an individual basis, because studies would indicate, and our own clinical experience would indicate that that probably has less toxicity long-term than whole brain radiation, where the entire brain is treated to lower doses. Whole brain radiation, though, sometimes is appropriate for patients with innumerable metastases where you just can't actually target each one individually. One of the really exciting things that's been going on in the past number of years is that some of the second and next generation targeted therapies for EGFR and ALK are actually now able to get into the central nervous system and control brain metastases. And that's really a paradigm shift for us in oncology. As oncologists, we're not used to treating brain metastases with systemic therapy, but now we're seeing that these drugs are actually effective for known brain metastases and for preventing new ones from occurring. And so as these drugs come into common practice, drugs like alectinib, ceritinib, and brigatinib, it's kind of changing our paradigms, where for patients who have asymptomatic brain metastases, we might be more willing to give a trial of drug with close surveillance and to see if those drugs are effective at controlling these lesions prior to moving towards radiation. And that's really an evolving paradigm that's very new, because these drugs are just now gaining FDA approval and becoming part of common practice for patients with ALK mutated lung cancer. So radiation is a very important component of the treatment of brain metastases, and I would say it's an evolving story as we're getting drugs that are better at actually treating brain metastases going forward. And then the second part of the question was, when might we consider surgery for a brain metastasis? So surgery can be a very important tool for treating lesions that are large and symptomatic with a lot of edema, which is the medical term for swelling. Any lesion can be treated with radiation, but if a patient is having bad headaches or seizures or a lot of symptoms from a large brain metastasis, we don't really expect the radiation to help those things resolve quickly, and sometimes surgery remains just the best option for those patients. So it's an individualized question, but surgery, if we're in an instance where there's an emergency and we need to correct neurologic symptoms very quickly from a large metastasis with swelling, I think that that's a time where we would strongly consider surgery. But for patients who don't need surgery, we tend to favor a radiation-based approach, just because it's a non-invasive treatment that doesn't require hospital stay and is generally a little bit safer. And so that's our general approach.
Thanks very much, folks.